passing examination is a separate act. Practicing cardiology is a different act. You have seen your teachers telling several times, an average student just like passes, a brilliant student makes a big mistake. So it is not academics, more than that it is interpersonal relationship, your body language and the way you put up. So first thing I would say is, because you get DM today, your life is not going to change tomorrow. Okay? Maybe if not today, you will get it in 6 months. So be composed. It's your tension which eats away everything. You are not able to recall your answers and you give a very, very wrong answer. The examiner jumps on the table. What is this? You say. Like you say the patient has mitral stenosis and casually mention that there is S3. So be calm, compose. Just because of a single examination result, you are not going to change your lifetime. Nor because getting DM this year, tomorrow you are not going to become a very big person. It takes time. You start learning only after the examination. So most important thing, calm, compose, do take your breakfast. I have seen several diabetic candidates not taking breakfast and just before getting into the exam room, sir, can you get anything to eat? I feel hypoglycemic. Okay, first, when you get into the examination hall, greet all the examiners equally. Don't look into the eyes of your internal examiner alone. Then the external examiner might get little bit irritated. After all, human beings are egoistic. Okay. Then, of course, you start explaining about the patients. Make sure that once you have finished your examination, that is what I mean to say is your examination outside the examination room, wherever you see the patient, sit, think for 10 minutes, put all the points in a proper way, chronologically and logically. Okay, and then you mentally prepare yourself what you are going to say. For example, you cannot straight away argue for a rheumatic heart disease in an elderly patient of 60 years, nor a degenerative disease in a young patient of 24 years. When you analyze the symptoms, if the breathlessness has started acutely within few days, either you should consider a diagnosis which starts acutely, or there has been a chronic problem, on top of it something has made it acute. For example, an RSOV starts acutely and then little bit of abatement and worsens. Whereas a chronic rheumatic heart disease, the patient might be having symptom for a long period. Suddenly an infective endocarditis or a fly leaflet happens, he becomes grossly symptomatic. So from the history itself, you will be able to tell that something has happened more recently. See, understand, you don't think that the examiners are not going to take a detailed history. Just in 3 words, they will fix the history. Because they have that experience. So, you know that the examiners will be, when you yourself are tired in seeing too many cases, in the situation of passing your examination, think about the examiners who don't have that stress. So, they will be looking at the case in a more logical way. Each step, the history, the next step fits into each thing. See, if you start contradicting your own history, definitely you will pick up the mistake very easily. Either your history is wrong or your examination finding is wrong. An experienced teacher doesn't need much time to differentiate between these two. Of course, as Dr. Balachandar pointed out, you will be given all the tips about the case in your institution. You know the X-ray, echo, MRI, what not, anything more than that. But please understand, you keep it at the back of your mind. Never introduce it before clinical examination. Just because you have found a lesion in the echo, you don't incorporate in the history or in the clinical finding. If there is no appropriate clinical finding, just make it a point not even to utter a single word about the diagnosis. The moment you utter that particular clinical finding, when it is not there, your examiner knows that you have been tipped too much. Okay, so don't try to fix the diagnosis by giving your own findings. So I would prefer you not to see the echo at all, but I know all your senior and junior friends would have given you a lot of information about the cases. So don't come with a preformed idea into the examination hall, and try to understand when you are given clue, take it with a pinch of salt. Don't take it just like that because somebody has given you a clue. Don't try to justify it in the examination without adequate physical finding or history. The most important thing, all the examiners come to give you a pass, not a fail. At least for the last 5 to 6 years, I know. There is no examiner who comes with the intention of giving you a fail. Please understand. Okay, it is only you make him to give you a fail. So, be calm in approaching the exam. You have your thought process properly aligned before you get into the examination hall. You will have 10 to, even though they say the exam time is 1 hour, I am sure all the institutions make sure that you get at least 1.5 hours in addition to clues. And all the examiners also know, they also know that, okay, fine, chalte hai, you let him take 10 minutes, that is not the problem. We are not bothered about whether he knows the diagnosis or not. We are bothered about how he approaches the case. Maybe your diagnosis is diametrically opposite to the real diagnosis, but it doesn't matter. As long as you have approached it rationally and you are able to justify it with your knowledge. So please note that that man told there is a continuous murmur there, this man told there is S4, he told that there is loud S1, and then you put everything together, nothing goes in glove in hand. So whichever you feel correct, you give. Please think before you take up the clues from your friends. Don't get into the hall with the preformed diagnosis and preformed ideas. For example, you have taken an AF, then once you have an AF, you should have logically A wave is absent. Your A to OS interval will keep on varying, S1 intensity will keep on varying. So AF is a hard sign. So once you know the patient is having AF, you should be able to think in your mind and adjust your clinical findings accordingly. As I told you, just because the patient has an MR and an MS, if you are going to put MS as at least mild to moderate, you should not invoke an S3. So this happens always in the multivalvular heart disease. You are not able to say when the examiner says which one is dominant. So always I would prefer you to commit one as severe and one as mild. Don't put moderate because you don't have criteria for moderate. Either one is mild or one is severe. In moderate is in between. But doesn't mean sometimes you may have to commit, but a non-average. So it's a logic that matters. And whatever you say, know and say, don't tell just because yesterday I have read in one book. See, for example, anthropometric measurements. And this another one thing is negative history. You keep on telling 20 negative history which is irrelevant to the case. Now it starts irritating the examiner. Now he says, why do you ask this negative history? Can you tell what is the basis behind it? Then you get stumbled. No sir, as a routine I asked. You are a consultant of a super specialty. There is nothing called a routine. Everything is focused. That is why patients are coming to you. Otherwise, they should have gone to a general practitioner. You are focused. What do you want right from the history? As Sarah told, if the patient complains of palpitation, you just don't accept it. You go beyond that. What is the onset? What is the offset? What is the precipitating factor? Was it rapid or was it slow? Something like that. If you know that it is only exertional, slow onset, slow offset, probably volume overload. If it is not related to exertion, coming at rest, there is no specific relation to anything, sudden onset, sudden offset, then it is not a volume overload, it is arrhythmogenic. So that is the way you go about. So never concoct findings. Clinical findings, whatever is there in the patient, you tell. If you are doubtful about the finding, you say, I am doubtful about the finding. And another important thing, whenever you are asked by the examiner, do you want to go and re-examine? So if you think you are doubly correct, Go, examine, come back and tell the examiner, no sir, still I feel this is the finding. Don't tell, no sir, it is correct. Don't go back, without going back, examining and coming back. If you think the examiner is giving you a clue, my personal opinion, no examiner wantonly makes you the other way around. He never guides you to make a mistake. Just he wants to check, are you sure in your findings, or the other way around, he wants to give you a chance. So accept it, go back, review it. If you think you are wrong, first accept to the exam that you are wrong. So don't be telling that no sir, this is the finding, that is the finding. Maybe that you have read some article yesterday which the examiner has not read, but doesn't mean that he will not know anything. Out of his experience, he will know much more than what you know. So please do accept graciously if the examiner points out that it's a mistake. It's a mistake. Sorry sir, I will change. These things always come in the grading of severity of lesions, particularly this parasternal heaves. As he told, always go with the company. You can't tell one finding and no P2 loud, no palpable pulsation, no significant elevation of JUP. You say parasternal heave matram, it's grade 3. So I am saying it is severe pulmonary hypertension, sir. Just because somebody has given you a clue, the TRPG is 60 millimeter in the echo. Don't do that. Okay. The examiner also knows, he has also gone through the examination. And as I told you again and again, you be calm and composed, and the examiner doesn't come to give you a fail. All the examiner wants to give you a pass, unless otherwise you make yourself non-deserving. Of course, you should have a basic theoretical knowledge. So I would expect you to definitely read a couple of books, not all the books in the subject, and particularly not the recent published articles for clinical examination. Take up a standard textbook, for example, Branwall clinical examination. If you can, Huss clinical examination, Jonathan Abraham's clinical examination. Be clear with what they have given. So congenital heart disease, Perloff, Mason Adams. Maybe you can read Freedom and all the other things, but it is difficult for you to remember everything and recall it in the examination at this point of time. Once you finish, then you have to go and read much more than this. That's a different story. Our aim here is to pass the examination. As simple as that. After passing the examination, you will read cardiology for the joy of reading cardiology and enjoying and treating the patient. Now you are under tension, so you are reading cardiology for the sake of passing cardiology. So at that point, you should know what is the minimum basic mistakes you should not do grossly. Nobody wants to know what is the highest level of knowledge you have. Everybody wants to know, do you have enough knowledge so that when you are left into the community, you don't do any harm to the public. So that is the principle. All the examiners, all the senior examiners, they all know you make mistake. Even the best of the best candidates make the worst of the worst mistakes under the examination situation. They know it. See, they have trained a lot of students. They have their own kith and kin, son, brother who have been doctors. They know the stress of undergoing this course. But they also have the responsibility of training you to the basic standard, basic minimum when you are let into the community. So I will stop here. So it is the approach in a calm way, your interpersonal relationship, and the logical thinking. That is cardiology, we call it a detective cardiology. Just as in congenital heart disease, you go segment by segment. Yes, what is the atrial situs? What is the ventricular situs? What is the arterial thing, relation? Then you assemble what is the atrial relation to ventricle, ventricular relation to great arteries, and then come to a conclusion. So that is the basic thing. See, there are these MS, AS, first heart sound, second heart sound, third heart sound, all those things, heavings, pulsations. See, all are discussed only with the final aim of coming to a conclusion. And quantification, because based on the quantification, you are going to decide the treatment. For example, a patient has an AF, he may be a little bit younger, immediately you jump for a tissue wall. Then the examiner says, no, already he has an AF. So anyway, you are going to put him on oral anticoagulants, so why don't you advise him a metal valve? Of course, things will change over a period of time, no acts and other things, but at present. So I think I will stop here. I don't want to bore you with academics. So I thought what I feel as an examiner, I am telling you. And do, when you are examining, when your examiner asks you to examine the patient in front of them, do treat your patients with respect and politeness. Okay? Don't command them. Your teacher. And do treat, see, you may be sitting in a big hall, you are tense with too much of AC. You will feel comfortable. The patient will not feel comfortable. So, do take care of the patient, do respect the patient. Okay, thank you. Best of luck.